End-of-life care. Overview of palliative and end-of-life care. Focus of care is comfort and respect for person nearing death and maximizing quality of life for patient, family, and loved ones. Palliative care is an approach that improves the quality of life of patients facing life-threatening illness through the prevention and relief of suffering, including treating pain, physical, psychological, and spiritual concerns. Appropriate for any patient at any stage of a serious or life-limiting illness. May occur in a hospital, hospice, in the community, or at home. Often involves an interdisciplinary team of caregivers, addresses the medical, psychosocial, and spiritual dimensions of care. Palliative sedation, the use of sedative medications for patients that are terminally ill to relieve suffering and manage symptoms. Though the intent is not to hasten death, this may be a foreseeable consequence. Withdrawing or withholding life-sustaining interventions, for example, artificial ventilation or nutrition, that are keeping the patient alive but no longer wanted or indicated. Euthanasia and medical assistance in dying. Euthanasia, knowingly and intentionally performing an act with or without consent that is explicitly intended to end another person's life, where that person has an incurable illness. Medical assistance in dying, the administering of or prescribing for self-administration by a medical practitioner or nurse practitioner of a substance at the request of a person that causes her death. Common ethical arguments, opinions. Criminally prohibiting medical assistance in dying may influence some individuals to end their own lives and or to endure intolerable suffering until their natural death occurs. Patient has the right to make autonomous choices about the time of their own death. Belief that there is no ethical difference between the acts of euthanasia, assisted suicide, and foregoing life-sustaining treatments. Palliative care, not the same as medical assistance in dying. Palliative care is an approach designed to improve symptoms and quality of life for the duration of a person's life, but unlike medical assistance in dying, it does not aim directly at or intend to end the person's life. Many palliative care physicians are incorporating MAID into their practice, though some may conscientiously object. MAID means medical assistance in dying. The continuation of the common ethical arguments and opinions. Believe that these acts benefit terminally ill patients by relieving suffering. Believe that patient autonomy has limits and that one cannot and or should not be allowed to make an autonomous request to end one's life. Death should be the consequence of the morally justified withdrawal of life-sustaining treatments, only in cases where there is a fatal underlying condition, and it is the condition, not the withdrawal of treatment, that causes death. An argument presented in the Carter case, see below, suggested permitting MAID, medical assistance in dying, will detract support for palliative care, since with proper palliative care the number of requests for MAID would increase. This argument was rejected in Carter v. Canada as it was deemed unacceptable to make people suffer intolerably to potentially improve and or increase support for palliative care. Legal aspect. In the Carter v. Canada decision of February 2015, the criminal prohibition on assistance in suicide was ruled unconstitutional to the extent that they prohibit physician-assisted death for a competent adult person who 1. Clearly consents to the termination of life, and 2. Has a grievous and irremediable medical condition that causes enduring suffering that is intolerable to the individual in the circumstances of his or her condition. Bill C-14 of June 17, 2016 legalized MAID by amending the criminal code to create exemptions permitting medical practitioners to provide MAID, specified the eligibility criteria, safeguards, and required documentation and authorization from the Minister of Health, as well as new offenses for failure to comply with the new regulations. And there is the link. Assent as the Bill C-14 criteria are narrower than the Carter decision, there are ongoing constitutional challenges to the MAID framework as it currently stands. Bill C-14 criteria for MAID, medical assistance in dying. Patient is eligible for publicly funded health services in Canada, at least 18 years, and has capacity for clear and freely given consent, grievous and irremediable medical condition, in an advanced state of irreversible decline in capability, suffering intolerable to the patient, not relieved under conditions they consider acceptable. Recent update eliminated criteria of reasonable foreseeability of natural death. MAID process. 9 points. 1. Eligibility criteria satisfied. 2. Patient signs and dates a written request for MAID. 3. 2 independent witnesses sign the written request. Witnesses must be 18 years old, understand the nature of MAID, and must not a. Benefit financially or otherwise from the death, b. Be an owner or operator of the healthcare facility where the patient is receiving care, and c. Be directly involved in the provision of health or personal care of the patient. 4. HCP must inform the patient, healthcare practitioner must inform the patient that they can withdraw their consent at any time. 5. 2 independent assessors, physician or NP, nurse practitioner, must provide written confirmation that eligibility criteria are met. 6. 10 clear days must elapse between the request and the day on which MAID is provided, unless both healthcare providers agree that a shorter period is appropriate due to the patient's imminent death or loss of capacity. 7. As per the new MAID legislation updated in 2021, a patient may request MAID even if death is not reasonably foreseeable. For a patient whose death is not reasonably foreseeable, their eligibility assessment must be a minimum of 90 days unless the assessments are completed sooner and the patient is at immediate risk of losing the capacity to consent. 8. Throughout the 10 or 90-day period and immediately before providing MAID, the healthcare practitioner must give the individual an opportunity to withdraw the request and ensure that the patient gives express consent to receive MAID. Contravention of this process is an offense punishable by up to 5 years in prison. 9. As of changes to the legislation in 2021, a patient may waive the requirement for giving final consent just before MAID is administered only if 1. The patient's death is reasonably foreseeable, and 2. While the patient has decision-making capacity, the patient is a. Assessed and approved for MAID, be advised that they are at risk of losing capacity to provide final consent, and C. The patient makes a written arrangement with their healthcare professional where they consent in advance to receive MAID on a chosen date if they, that is, the patient, no longer has capacity to consent on that date. Let's read the blue boxes. MAID. Ethically appropriate actions. Respect capable decisions to forego available treatment options and/or palliative care options. Provide appropriate palliative measures with patient consent. Try to assess reasons for MAID requests to see if there are reversible factors that are directly and unduly influencing one's desire to receive MAID. For example, depression, pain, loneliness, anxiety that can be treated. Exploring the experience of supporting a loved one through a medically assisted death in Canada. Okay, this is a publication, CanFam Physician, 2018. Purpose: to explore the experience of family and close friends of patients seeking MAID in Canada. Methods: primary support givers of clinic patients seeking MAID were identified during consultations for an assisted death evaluation. The identified support givers were then invited to participate in the study, and those interested were asked to contact interviewers. Semi-structured interviews were conducted, transcribed, coded, and subjected to content analysis to elucidate common themes. Qualitative research then. Results: 18 support people for patients seeking MAID were interviewed. All participants were supportive of their loved ones' wishes for MAID and provided emotional and practical support in preparation for the procedure. Some participants reported feeling opposed, however, changed their minds after seeing the suffering their loved ones had to endure. The time before the procedure involved saying goodbye and ceremonial rituals. Those interviewed after the procedure found death peaceful and reported that it offered advantages compared with natural death in their loved ones' individual circumstances. Conclusion: participants were supportive of their loved ones' wishes for assistance in death to end suffering and found the process to be peaceful overall. Acceptable use of palliative and end-of-life care. The use of palliative sedation with opioids in end-of-life care, knowing that death may occur as an unintended consequence, principle of double effect, is distinguished from euthanasia and assisted suicide, where death is the primary intent. The appropriate withdrawal of life support is distinguished from euthanasia and assisted suicide, as it is seen as allowing the underlying disease to take its natural course. But this distinction may be more theoretical than real. Consent for withdrawal of life support must be sought from the capable patient, or in case of incapable patient, the SDMs, the Substitute Decision Makers, as per the Healthcare Consent Act and Substitute Decisions Act, and as reaffirmed by the ruling in Cuthbertson versus Razoli in 2013, as palliative care would be instituted and consent for that would require SDM, Substitute Decision Maker, consent. Refusals of care by the patient that may lead to death, as well as requests for a hastened death, ought to be carefully explored by the physician to rule out any reversible factors, for example, poor palliation, depression, poverty, ill education, isolation, that may be hindering authentic choice. Government of Canada, Services and Information for End-of-Life Care. Here we have the link. Options and decision-making at end of life. Palliative care, do not resuscitate orders, refusal or withdrawal of treatment, refusal of food and drink, palliative sedation, and medical assistance in dying, MAID. Decisions at end of life. Informed and capacity for consent, substitute decision maker, advanced care planning, written plan, will or medical directive, often established through a family meeting. Let's read the blue box. Notify coroner if death occurs due to violence, negligence, misconduct, pregnancy, sudden or unexpected causes, disease not treated, cause other than disease, suspicious circumstances, and MAID also, medical assistance in dying, should also notify the coroner. Physician responsibilities regarding death. Physicians are required by law to complete a medical certificate of death unless the coroner needs notification. Failure to report death is a criminal offense. Coroners Act, 1990. Specific to Ontario, similar in other provinces. Requires physicians to notify a coroner or policy officer if death occurs due to violence, negligence, misconduct, misadventure, or malpractice, during pregnancy or is attributable to pregnancy, suddenly unexpectedly, from disease which was not treated by a legally qualified medical practitioner, from any cause other than disease, under suspicious circumstances, and death from medical assistance in dying, MAID. Coroner investigates these deaths as well as deaths that occur in psychiatric institutions, jails, foster homes, nursing homes, hospitals to which a person was transferred from a facility, institution, or home, etc. In consultation with forensic pathologists and other specialists, the coroner establishes the identity of the deceased, where and when the death occurred, the medical cause of death, the means of death, that is, natural, accidental, suicide, homicide, or undetermined. Coroners do not make decisions regarding criminality or legal responsibility. While the Supreme Court of Canada noted that nothing in the Carter v. Canada decision compelled a physician to participate in MAID, the College of Physicians and Surgeons of Ontario mandatory referral policy, which has been upheld by the courts, requires physicians in Ontario to provide an effective referral if the physician conscientiously objects to MAID. The impact of MAID on religious institutions' obligation towards patients is not yet clear. That's it. Next video, physician competence and professional conduct.